So, good afternoon, friends. And as a continuation of the session for today, we have seen about the indications for RRT, the modalities for RRT, and the physiology and the rationale for initiating renal replacement therapy in the intensive care unit. But one of the most difficult decisions in the intensive care unit, or probably an area of conflict in the intensive care unit, has been the timing of initiation of RRT in the ICU. Whether you start early, whether you start late has been a point of debate, and it always leads to a difference of opinion between the treating teams, and it is a point where you need to walk a tightrope to explain to the family whether you'll be starting the renal replacement therapy or not. The background against which this topic can be discussed or evaluated is that RRT is a very common intervention in the intensive care unit. After invasive ventilation and hemodynamic support, probably this is the most common intervention which is administered to patients in the intensive care unit. Unlike about 10-15 years ago, several modalities are available in the intensive care unit for the delivery of renal replacement therapy. You have intermittent hemodialysis, you have SLED, you have CRRT, and you have different other modalities as well. And there is some school of thought which believes that even PD is feasible in a critically ill patient. The common indications for initiating RRT in a critically ill patient are acidosis, hyperkalemia, azotemia, and fluid management. So these are the common ballpark criteria by which we tend to initiate patients on renal replacement therapy. Early initiation is expected to improve the survival and shorten the recovery time of the patients. But if you speak strictly about evidence-based medicine, the evidence in favor of an early initiation of renal replacement therapy is very weak. So what do we need a consensus before we reach a decision on the timing to initiating renal replacement therapy? First, survival. Does initiation of renal replacement therapy have a bearing on the survival of an ICU patient? And this survival is immediate. That means while the patient is in the intensive care unit, in hospital, that means before he goes home, and within 60 days and within 90 days. These are the standard parameters by which survival of any intervention or any condition in the intensive care unit is measured. If it doesn't improve or impact survival, does it at least impact the length of stay in the intensive care unit, or does it at least impact the length of stay in the hospital? If these two are not the parameters, then you need to look at whether the patient is dependent on RRT, or has he got off the ventilator quicker if the RRT was initiated faster, and has it resulted in lesser complications if you initiate RRT later. So these are the parameters or metrics on which we need a consensus when we talk about the evidence-based review of the timing of RRT. But there are different confounding issues for this topic. One, the case mix. In an intensive care unit, when you apply renal replacement therapy, different patients with different diseases are clubbed together and you make a judgment. So a heart failure patient, an ARDS patient, a trauma patient, a pregnant lady, and a toxicology patient. These are all patients who undergo renal replacement therapy for different indications, and their outcomes may be different because of the nature of the underlying disease. But when you mix this data and then you come to a generalized conclusion, the extrapolation is to a general cohort of patients. Disease severity is also an important aspect. Are we trying to look at patients with the same degree of severity and then say that renal replacement therapy initiation should be early or late? And what modality has been used? Have we all compared only intermittent hemodialysis? Have we all compared only CRRT? Or have we all compared only SLED? And if we have only compared SLED, have we compared the duration of RRT? Has it been only for a 6-hour SLED or an 8-hour SLED? Or has it been a CRRT that's gone for 48 hours? So these are all the confounding issues which have a bearing on the timing of RRT and its benefits for a critically ill patient. One of the first recent studies which has actually evaluated this question came from Germany by Zarbach in the year 2016, where they studied whether the early initiation of renal replacement therapy and its impact on mortality in critically ill patients with acute kidney injury, called the ALIGN trial. This was a single center prospective randomized controlled trial in German intensive care units, randomizing about 231 patients, where they measured the patients with they diagnosed AKI based on KIDIGO, and most of these patients were KIDIGO 2 and 3, and they had a biomarker elevation as well, serum NGAL of more than 150 nanograms per ml. But most of them, 80% of this cohort of patients is surgical patients, predominantly cardiac surgery. And they looked at mortality as the primary outcome, and time in on RRT and renal function recovery and hospital stay as the secondary outcomes. If you look at patients who had KIDIGO 2, with an early strategy where dialysis was initiated or renal replacement therapy was initiated within less than 8 hours, the mortality in the early group and the group was a little better in those in whom you had actually a early initiation of RRT, and they had lesser time on RRT, and the renal function recovery was more in those in whom early initiation of renal replacement therapy was initiated. So this group concluded that among critically ill patients with acute kidney injury, early RRT compared with delayed initiation of RRT reduced the mortality over the first 90 days. But as I said, this is a single center study with a predominantly post-operative cohort of cardiac surgery patients with an AK-KIDIGO category 2 and 3 of dialysis. So highly focused and may not be extrapolatable to other K patient cohorts. Then came a study, another study from France, which looked at it is a multi-center prospective unblinded randomized control study looking at 31 ICUs, which randomized more number of patients who required invasive ventilation, which is the more of a prototype patients which we see in the intensive care unit. Again, KIDIGO 3 category patients where there was ischemic or septic injury and required vasopressor therapy. They looked at it had about 30% of the patients had CRRT, and half of them had intermittent hemodialysis. So they initiated early dialysis within 6 hours, and the delayed strategy would be decided based on an emergency needed for dialysis. And they also looked at mortality and RRT free days and mechanical ventilation free days. At the end of the study period, no difference was found in the mortality in this cohort of patients where initiation of dialysis was done within 6 hours versus beyond 6 hours. Then the RRT requirement was less in those in whom delayed initiation was needed, and more patients actually stayed off the renal replacement therapy at the end of the study period. And there was no difference in the vasopressor requirement, but less number of patients actually got off the mechanical ventilation in the RRT, early initiation of RRT. So Gaudry et al. Concluded that in a critically ill patient with severe AKI, there is no significant difference with regard to the mortality between an early and a delayed strategy of initiation of renal replacement therapy. A similar study was published the next year, called the Ideal ICU study, to identify whether there was an ideal time to start renal replacement therapy in patients with acute kidney injury, specifically focusing on septic shock patients. And again, this was a multi-center randomized controlled trial by Barber et al. In 29 ICUs, randomizing about 500 patients, looking at rifle category, where the rifle F was considered as the diagnostic inclusion criteria, and they predominantly looked at septic patients, and more than half these patients required CRRT. And the early initiation was within 12 hours, and late initiation was beyond 48 hours. Also looking at mortality, need for renal replacement therapy, RRT free days, and mechanical ventilation free days. Again, there was no difference seen between early initiation of RRT, read here predominantly CRRT, versus those who got beyond 48 hours. And there was no difference between the vasopressor days or the mechanical ventilation free days between these two categories of patients. So which means that early initiation of septic RRT, including CRRT, in septic shock patients did not result in earlier liberation from either dialysis or from mechanical ventilation, or did not confer a survival advantage. So septic shock patients who had severe acute kidney injury did not show a statistically significant difference in overall mortality at 90 days between early initiation of renal replacement therapy and a delayed for strategy of delayed initiation. Now, the last one which we should talk about is the START-AKI study, where the question was asked whether by Sean Bergso, where does early initiation of renal replacement therapy decrease the mortality? This was a multinational open-label randomized controlled trial across 15 countries involving 168 hospitals over 4 years, looking at patients with KDIGO stage 2 and 3 critically ill patients, where a standard strategy of care was compared to an accelerated strategy where RRT was initiated within 12 hours of identification of an indication. And they looked at mortality at 90 days, renal replacement therapy dependence, and adverse incidents. And the early strategy, while did not confer mortality advantage, was associated with a higher incidence of adverse events and higher dependence on RRT at the end of 90 days. So, Bagshaw concluded that among critically ill patients with acute kidney injury, an accelerated renal replacement therapy is not associated with a lower risk of death at 90 days than a standard strategy. So if you compare all these studies, the ELAINE, the AKIKI, the IDEAL ICU, and the START-AKI study, the ICU length of stay did not differ across the groups, even in the one positive ELAINE study. The unique findings of these studies are that in the ELAINE study, in the AKIKI study, 61% of the survivors did not receive renal replacement therapy and had lower infection rates. The ventilator time somehow is not correlating with the need for renal replacement therapy. But the one difference between all these studies is each one has a different timeline. AKIKI had 6 hours, IDEAL ICU had 12 hours, ELAINE had 8 hours. So the time for which you initiate RRT is not very clear. But what is very clear from the START-AKI study is that even after 12 hours, if you wait and start, that within 12 hours, the advantage of the early initiation of RRT is not very significant. So needless to say, when there are such very good and big randomized control trials published within a short period of time, it will trigger a series of meta-analysis, and the same thing has happened for this as well. In 2021, we saw at least 4 meta-analysis published on timing of RRT. That one in the nephron, early versus late initiation of renal replacement therapy, in the Journal of Intensive Care Medicine, the Intensive Care Society, in the Journal of Critical Care, and of course in the Cochrane analysis in critical care medicine. So if you look at the all-cause mortality, early initiation of RRT did not confer any benefit when compared to delayed initiation of renal replacement therapy across the studies from 2002 to 2020 with significant heterogeneity, but the I-square is fairly good. So they have not deviated much from the null effect point. If you break it down into subgroups, whether it's surgical and high SOFA versus low SOFA, diabetic patients, and based on urine output, depending on centers, and in septic patients, in fact, in septic patients, late initiation was associated with better outcomes, and non-specific causes probably did not make any difference. However, we can say that in diabetic surgical patients, initiation of a non-CRRT in a non-oliguric patient is associated with a better outcome. That is logical, since a non-CRRT patient would mean that the patient is not hemodynamically unstable, and non-oliguric means there is a preserved renal function. Such patients are less sicker and would likely to do better either way, whether you initiate the RRT early or late. If you look at the ICU mortality, there has been absolutely no difference in some of the studies which used ICU mortality as a metric, and the meta and the forest plot is absolutely on the midline. So there is no advantage in terms of ICU mortality. Neither there is any advantage on 28-day mortality. If you look at extended period of time of 90-day mortality also, right from the Zarbach study of 2016 up to Bagshaw's paper of 2020, there is hardly any difference between early initiation of RRT and delayed initiation of renal replacement therapy. Does it impact the length of stay in the ICU? Yes, but that's very, very marginal. The confidence intervals are extending on either side of the midline. So you cannot say that early initiation of RRT confers any significant advantage over delayed initiation for the length of hospital stay. What about hypotension? The incidence of hypotension after initiation of dialysis, surprisingly, seems to be a little bit more when patients are initiated RRT early. Again, you can see the Zarbach study, the Jamal study, Barber's paper, which we discussed, and the Bagshaw paper. So there is a tendency for delayed dialysis RRT initiation to be favored for intradialytic hypotension. So if you allow the metabolic parameters to be settled, the resuscitation to be sustained and stabilized for a little more period of time, and then initiate RRT, probably your results are going to be better. Needless to say, early initiation of RRT was associated with a greater infection rate because these patients who are hypotensive, hypothermic, acidotic will have a higher predisposition for infection than when you initiate the RRT in a delayed sort of way for these patients. And incidence of arrhythmias also seems to be a little better or is lesser in patients in whom you have a delayed initiation of renal replacement therapy. If you understand the incidence of arrhythmias and their consequences in the intensive care unit, an acidotic patient's arrhythmia is more difficult to correct. So if you can correct it a little better, if you resuscitate the patient a little better and then initiate RRT, the arrhythmia may be better managed. Bleeding events are not very different. So early initiation versus late initiation, there is no big difference between the bleeding events. At the end of 90 days, the most important finding from all these studies is that dependence on dialysis is less when you initiate RRT a little later in the intensive care unit. So dialysis dependence on day 90, if you take it as a matrix and as a metric, then there is a definite advantage for delayed initiation of renal replacement therapy. And more patients would probably stay without dialysis when dialysis is initiated late. So do we have a consensus on this issue? Does early renal replacement therapy improve immediate survival? The answer is no. Does early RRT improve hospital survival? Answer is no. Does early RRT improve long-term survival? The answer is no. Does the early RRT shorten the length of stay? Answer is no. And does it decrease the complication rate? Answer is also no. But heterogeneity in the studies is an issue. Of course, there are few studies which have looked at only septic patients, only surgical patients, but in a general intensive care unit, what is the outcome? We do not yet know. So in the severity levels, the Apache scores in most of these patients range between 18 to 26. So what happens to those whose scores are above 25 or above 23, we do not know in a focused sort of way. Most of these studies recently have focused on CRRT as the primary modality, which availability again is a big issue in this country. So what happens if you initiate SLED in these patients is not answered. So we know that initiation within 12 hours is early, but how late? Is 48 hours too late? Is 36 hours too early? That's the question which is yet to be answered. So these are some of the unanswered questions still in the timing as the issue related to the timing of renal replacement therapy. Thank you very much for your attention, and we can take few questions at the end of this session.